Hello and welcome to Cutting Edge Pain Relief. Today, I have the distinct pleasure of having Jessica Glassman with South Bend Neurology here to talk about an incredibly important topic, which is the context of overuse medication and headaches associated with it. And we're really going to delve into this topic so people can have a greater understanding about how important it is, how nuanced it happens to be, and really how can you be able to treat/avoid it. Jessica, thank you so much for joining us.
Hi, Dr. Landrum. Thank you for having me.
Thank you for being here with us. We really appreciate you being here with us.
Oh, yeah. Glad to be here.
As I understand it, you deal with all types of neurologic complaints, and one of the things that's really prominent is headaches, and it's a part of your regular practice. Can you explain some of the common types of headaches that you deal with?
Yeah, so I work in general neurology, but I do have a headache certification through the National Headache Foundation. So I deal with all sorts of headaches. So migraine, tension type headache, those are for sure the most common types of headache that we see. There's a bunch of more rare headaches that we deal with as well, but those obviously don't happen as often. And I do deal with a good amount of medication overuse headache that I see on a regular basis.
Okay, and how does medication overuse headache differ from other headache classifications?
So medication overuse headache is what we call a secondary headache. So it's caused by something else. So medication overuse headache is caused by the overuse of different kinds of medication. When you see medication overuse headache, it can present in several different ways depending, but it's a secondary headache. So it's not a primary headache, there's something causing it.
Is this pretty common or is it rare? I mean, does this really happen to quite a few people?
Yeah, so in the general population, it's about 1 to 2%, but in the population of people who have chronic daily headaches, it's about half. So in any new patient that I get with migraine or tension type headache or a chronic daily headache, it's about half of those people that come in to see us. So it's pretty common, really. We see it all the time.
So in terms of risk factors, are there a certain number of days of medication use that can predispose you or potentially have you be likely to present with a problem like this?
Yeah, it depends on the kind of medication. So people that are on opiates, ergotamines, triptans, usually about 10 days a month or more can cause medication overuse headache. People that are on over-the-counter medications like nonsteroidal anti-inflammatories or Tylenol, 15 days or more a month can cause medication overuse headache. So just depends on the kind of medication there are and how common it is for that to cause medication overuse headache.
What are some of the symptoms and how would you go about diagnosing it?
So the symptoms tend to follow what kind of primary headache the person has. Most of the time when people present with medication overuse headache, they'll have an underlying primary headache. So they'll have underlying migraine or underlying tension type headache. And the medication overuse, when they keep using the medications, it tends to exacerbate that headache type. So people that have migraine present with light sensitivity, sound sensitivity, nausea, and then there's some other migrainous symptoms that can go along with that. People with tension type headache tend to get like a banding, squeezing headache that's pretty bothersome. And so it just kind of depends on what their underlying headache is. That medication overuse headaches tend to happen more in the morning and tend to happen when the medication wears off. So people will take the offending agent and then their headache gets better after they take it, and then it comes back after the medication wears off, and then they have to keep taking the medication to take care of their headache.
Sounds kind of like a vicious cycle.
It is a bad cycle, yes. It's hard to break.
You mentioned opioids as a potential causative agent. Are opioids themselves, do they always have to be utilized by that person for the headache, or could it be even used for some other type of pain that might be kind of causing their primary headache to have this issue that's associated with it?
I see that often where people are prescribed opiates for a different indication, and they have generally they have an underlying headache disorder, primary headache disorder like tension type or migraine, and then they take their opioid or their oxycodone or their hydrocodone or whatever, and then it just exacerbates it. So it causes medication overuse headache because they're taking it so frequently. So that's a very common problem, and it really complicates headache treatment for sure.
So, nice lead in. Really appreciate it. So, that being the case, then how do you treat this? What ways do you figure out, how do you be able to deal with it? Do you stop it cold turkey in terms of meds? Do you wean it? What are your thoughts? And what's the best way to be able to get treatment that gives you a good response?
Yeah, well, and that gets complicated depending on what the offending agent is. So if somebody's taking an over-the-counter medication like Tylenol or ibuprofen, normally what we do, so we want to treat their underlying headache disorder as well as the medication overuse headache. So what we'll do is we'll find a preventative medication for the underlying headache, and then we will, if it's medication that you can't stop cold turkey, we'll do that, and then we'll bridge the patient. So that's like a transitional medication that we give them for 10 days to 2 weeks, just because your headaches are going to get worse once you remove the offending medication for 2 weeks. And so sometimes it gets really difficult to get people off of these medications just because that bridging period can be kind of intense. So then we'll bridge them with a different medication, a second medication. Oftentimes that's prednisone. I've used triptan. It can't be in that same class, so it has to be a different kind of medication. So triptan medications, I've used hydroxyzine, ergotamines, just whatever works best for that patient depending on their medical history and comorbidities. It gets more difficult when people have medication overuse headache due to, say, Fioricet or opioids or something that you can't stop cold turkey. Those medications, sometimes you can stop and bridge with another medication to wean off, but a lot of times you need to do a very slow weaning process because of the difficulty of getting them off of that medication. And then we do give them a symptomatic medication on top of that to take in case they get a headache on top of the when they're taking that headache bridge or the medication overuse headache bridge.
So you mentioned kind of that symptomatic meds and preventative meds. Are there certain ones that you use more commonly, kind of in that context for each of those?
Yeah, I think that depends on what else they have going on with their health history, what other triggers they have for their headaches, contributing factors. There's just a myriad of medications that we use for preventatives for headache. And for sure, tension type is treated differently than migraine. So Botox is a great one. We use that regularly. I'd say less so in the last couple years since these new injectable CGRP antagonists have come out. Those really have been a game changer.
All right. So hit on a hot topic
Yeah.
in addition to this. So can you talk a little bit about those meds? Because I'm not sure everybody knows about that. I know that, you guys are like super fancy and specialized, and you guys deal with this every day. And I think people see this, maybe on TV from time to time when you see the commercial come through and they're like, what is that medication? I don't think I've heard of that before. But can you talk a little bit about what those medicines are and how they're different than what has been traditional mainstay?
I would love to. So so calcitonin gene-related peptide is this peptide in your brain that causes migraine. And so what these medications do is they go and they work on that peptide to either block it or kind of take it away to reduce migraine frequency. Those are the injectables. So there's 3 of them. I actually have them behind me. There's 3 once a month subcutaneous injections, and they don't always work immediately. Some people do get pretty good response to them pretty quickly, but these medications kind of have changed the world of migraine treatment since they came out in 2018. And they really have low side effects. Aimovig is the first one to come out. That one can cause some pretty bad constipation, but it's transient. The other two, injection site reaction, Ajovy and Emgality, and they're usually very well tolerated, and people do very well on them long term. And they work very well for migraine prevention. They're only for migraine. They aren't used in tension type headache. There's a different treatment plan for that. So those are the three preventative injectables. There's also an infusion medication called Vyepti. And that medication hasn't been out as long, but the data on that is pretty amazing. And people in the study noticed a difference the next day. So those are the preventative medications. There's actually another one coming out. The American Academy of Neurology had a speaker on. There's a new oral CGRP medication coming out soon in that same drug class. So if people aren't into injections or infusions, they'll have another option. There's two, so on that same technology or that same theory, the CGRP, the calcitonin gene-related peptide, there's two abortive or acute treatment medications that are on the market right now, Ubrelvy and Nurtec. And they also really have very low, minimal side effects, and they don't work as quickly as I would like all the time. They're oral medications, but they really are. They're safe. You know, the triptan drugs that we've had out for a long time can cause a transient rise in blood pressure, which is a little bit of a concern, especially with people with coronary artery disease or a history of stroke. So those are safer medications that we can use in patients with migraine, and they're amazing. I think the biggest problem I find with these meds are that they can be cost prohibitive sometimes. So, a lot of times we have to do PAs or prior authorizations, or just check with the insurance to get them covered. And sometimes you do have to see a headache specialist or a neurologist to get them prescribed.
Thank you so much. I think you took all of the questions I was going to ask on that topic. You talked about, like, who is it indicated for? How does it work? All those type of things. And I think many patients would ask, well, is it something that they could start right away? And you covered all of that. Really appreciate it. So back to our kind of initial topic that we're talking about, are there ways to potentially be able to prevent this? Sometimes, before I kind of flesh that out, maybe you can kind of give us an idea about what way can we be able to prevent overuse medication headache?
Yeah, and I think that medication overuse headache frequently happens in well-intentioned people who are just trying to feel better. And we do want people to treat their headaches because, headaches going untreated can get worse. So it's kind of a sticky wicket, and it's a little bit of a balancing act. So generally speaking, you want to avoid taking any of the offending medications more than 2 to 3 days a week to avoid medication overuse headache. I think the other thing that should happen more often, and it's a lot of people wait to go see a healthcare provider to tell their primary care about their headaches until they get pretty bad, So I would say that bringing up the fact that you have headaches a little bit earlier would be a good thing too, just so, if the headaches start to chronicify, you can get on a preventative medication to cut down on how frequently they're happening, instead of taking those medications so frequently that just make them worse. So I think it's difficult too, because, I think headaches have so much of a stigma, and people don't like to talk about them or bring them up, or, they don't want to complain, when really they do significantly impact a lot of people's lives. So.
Now, I know that our primary audience is almost all people, patients, significant others of individuals that may have this problem. But for those healthcare providers that may catch this video either live or sometime in the future, are there things that we can do to try not to expose our patients to medication overuse headache as likely? What are some of the things that we can do to try to be able to be more judicious and preventative of that?
Yeah, and I think the biggest thing that people that work in headache medicine hate is Fioricet and Fiorinol. We hate Fioricet and Fiorinol, and I feel like some providers.
Why? Tell us why.
It causes so
Why
much.
do you hate?
Yeah, it causes medication overuse headache, and it's so hard for people to get off of it. And I feel like people don't generally respond well to it with their headaches either. It's a bad medication to get people on. So don't don't prescribe Fiorinol and Fioricet. I think that prescribing, you have to be very careful when you prescribe a daily NSAID to people, that they don't have underlying headache. And I think if people present with, chronicifying headache, you want to make sure that you're treating them with a headache preventative, as opposed to like just an abortive medication, if that makes sense. But trying to avoid chronic opiates and chronic NSAIDs and overusing triptans too. I've seen people come in that are using triptans, 20 some days a month, and that can also cause medication overuse headache. So.
Okay. Are there any alternatives that really have a backing in the literature other than medications for trying to be able to improve headache that you know of?
Are you talking about non-pharmacological methods for headache control?
Yes, that was the very fancy way of saying it. Yes, the non-pharmacologic methodologies. Yes, please. Can you give us some ideas?
Yeah, for sure. So, and that depends on the headache type, and that gets kind of difficult. So, there have been some non-pharmacological methods for headache control that are coming onto the market. The Cephally device is FDA approved for migraine. And I think last I checked, you don't need a prescription for that. It's basically a TENS unit that you wear on your head. And there's a couple of other devices on the market for migraine. I think it gets more difficult when you have tension type headache. I think that for sure working on triggers is important. So making sure you're eating regular meals, drinking plenty of water, reducing your stress as much as possible, getting regular exercise and watching your weight, and all of those healthy things for sure can reduce headache frequency too. And I think if a lot of us just worked on our general health, that would overall help our headache situation,
Okay. And so what should patients do if they suspect, they listen to this video, they heard the things that you were saying? What should they do in terms of figuring out, like, is this them? What treatment steps are next? How could they be able to get this resolved?
Yeah. I would talk to your primary care provider. I would try to limit the offending agent to 2 to 3 days a week if you can. Try to wean it down, or just limit it to 2 to 3 days a week, which is easier said than done for sure. And then talk to your primary care provider to get some help. And if they feel like you need to, they can always send a referral to a neurology practice so we can help you further. For sure.
Okay. So one of the questions I wanted to kind of pose to you is the following. Is there anything that I might have missed asking you that you think, this is a golden nugget that would be great for patients to know so they can have some further understanding about this topic?
Oh man. I think what I see is people just not getting care for their headaches soon enough. I think that's basically the problem. Is don't be afraid to talk to your healthcare provider about it. When you look at statistics about migraine, it's 20% of the people that just show up in the office have underlying migraine, and most people never bring it up. And then it just chronicifies and gets worse, and then you're miserable. And so, bring it up sooner to your primary care provider. Here at Neurology, we would love to see you for your migraines. And, just don't be afraid to talk about it. I think there's such a stigma with headache, and I think that, we're working on breaking that down and getting people treatment. And these medications that are out these days are amazing, and there's low side effects, and people do really well with them. So don't be afraid to get treatment if that's you,
So to that end, I've talked to a number of patients, particularly as a pain provider, and I think that sometimes they're afraid to go to neurology. I don't know why that is. I don't know why that seems so daunting, but I think patients are kind of like, well, does it require for me to see someone from neurology? what can help ease patients' concerns about being seen by someone from neurology to be able to help get better clarity about this problem?
Yeah, and I think when people come in, everybody's blood pressure is up because, I don't know, brains scare people. I don't know. Yeah, I think, we're regular people and we're friendly. We just want to help you with your issues. I went to neurology because I wanted to help people, and I thought headaches were interesting. And I mean it, and they are super interesting. Neurology is really a little bit the study of the unknown, right? A little bit, if we don't know what's going on, it must be neurology. So, it can be a little scary to patients, but, we're here to help you. We're not here to scare you or make you uncomfortable. We're just here to, you know, to help you along to feel better.
So without revealing, obviously, personal details for a patient, can you talk about a patient that had medication overuse headache that touched your heart and you were able to kind of treat them and they got a better response thereafter?
Oh, yeah. I mean, I think that, I've had a couple of those cases where they come in and they're just miserable and they're having daily headache, and they're taking, and they don't realize it. They have absolutely no idea that this daily ibuprofen that they're taking is causing medication overuse headache. And then you start them on these medications and you give them the bridge, and they come in and it's just life changing. They're able to go play with their grandkids and leave the house and do things that they were never able to do in years. And it's really, it makes you feel so good to help somebody like that. But
Okay.
yeah.
Well, I think that's kind of covered our topic in depth and detail. We definitely appreciate you joining us. And one ask that we'd like to put forth, because you've given us such insight about headaches, would you maybe in the future be willing to come back and talk about some other forms of headaches and let us know, the kind of nuanced pieces of like how to understand this, how it's affecting, how to be able to kind of, if you would, what are the things that are important? Because, you neurology guys and gals are super smart. So you have like a certain number of like days of this time at this frequency and this and that. And we're like, man, how do you remember all that? So particularly for the layperson, that would be incredibly useful if you're open to something like that in the future.
Yeah, it does get complicated. I'd love to come back and talk about
Again,
topics.
thank you so much for joining us. We really appreciate you being here, delving into this topic, which I think is a huge topic for patients that's not all that well known. We really appreciate those of you who are tuning in live and those who will be seeing this in the future. If you have interest in learning more about these topics, please sign up in our newsletter below. And definitely take a look at our YouTube channel so you can be able to see this topic and other topics that are contained there and figure out how you can be able to help punch pain in the face and get back to leading the life that you deserve. We really appreciate you joining us today. And thank you so much for being with us. Take care.